Currently a surgical pathology fellow, but I did a hematopathology fellowship last year. And I'm board certified in anatomical and clinical pathology and hematopathology. So today we're going to be talking about acute myeloid leukemia, basically the classification, and it's basically an overview of the different types of acute myeloid leukemia. This is a very long topic. It can take several hours, but we're going to try to talk about mainly the most important points. So we know that acute leukemia is generally divided into myeloid and lymphoblastic leukemias. The more common are the acute myeloid leukemias. And you diagnose leukemia when you see 20% or more blasts in the bone marrow or the peripheral blood, with a few exceptions. So sometimes you can diagnose acute leukemia without 20% blasts, and we're going to talk about the types of acute myeloid leukemia that can be diagnosed without the 20% blasts. So this is a slide that I had in my first presentation, and I highly recommend that you look at that presentation first, because it talks about it's more like an introduction to the cells in the bone marrow and what kind of cells compose the bone marrow and what they stain with, their markers, and the signs of dysplasia in each lineage. So I highly recommend that you look at that first. So basically all hematopoietic cells arise from the hematopoietic stem cell. And this cell has the capability of self-renewal. After that, it matures into either a lymphoid stem cell or a myeloid stem cell. The lymphoid stem cells mature into lymphoblasts, which can be either natural killer cells or small lymphocytes. And the lymphocytes, as we know, can be either T or B cells, and then the B cells mature into plasma cells. The myeloid stem cells will mature into one of the four main categories here, and these are what compose the acute myeloid leukemia. So it could be either megakaryocytic, erythrocytic, myelocytic, or monocytic. And we know that if it's a myeloblast, it can mature into a basophil, neutrophil, or eosinophil, which are the granulocytes. If it's a monoblast, it's going to become a monocyte and then a macrophage. Proerythroblast will mature into reticulocytes and then red blood cells. And megakaryoblast will mature into megakaryocytes, which produce the platelets. So our lecture is going to be concerned with this part of the diagram, the myeloids. Acute myeloid leukemia. So by definition, it's a clonal expansion of immature cells that arise from the myeloid progenitor cells of the bone marrow. These cells develop the capability of self-renewal and autonomous proliferation. Again, we have four morphological classifications, or four main groups, either granulocytic, monocytic, erythrocytic, or megakaryocytic. 70% of acute leukemias in general are going to be acute myeloid leukemia, so it's more common than lymphoblastic leukemia. In the US in 2017, there were 21,000 new cases of AML. It's typically a disease of adults around 60 to 70 years, and there's no gender predominance. The etiology, we always say some viruses can cause acute leukemia. Radiation, chemotherapy has been proven to cause leukemia, and in this case, we're going to call it therapy-related acute myeloid leukemia, and also benzene. Okay, basically when we get a case, bone marrow specimen, we get the bone marrow core biopsy, the aspirate smear, the clot section, the peripheral blood smear, and an iron stain. These are the slides that we receive for each and every case of bone marrow. So we do the peripheral smear count. We do the bone marrow aspirate count. So we have to have the CBC, the counts of each of the peripheral smear and the aspirate at the same time. We also we look at the cells and we try to figure out what type of cells are there, the number of each type of cell. And if we see blasts, we need to know the blast count and the blast morphology, trying to, classify this leukemia into each type. And we count the blasts in the peripheral blood and the bone marrow. After that, sometimes, of course, we don't depend only on morphology, but we do immunophenotyping, which means we detect the markers on the blasts. So we can do that either by immunohistochemical stains or by flow cytometry. We usually do both. So we order the stains on the same day we get the bone marrow, and then the next day we will get the stains. There are 5 main stains that we order on each bone marrow biopsy that we receive. So we do myeloperoxidase for myeloid lineage, CD34 and CD117 for looking at blasts, mainly myeloblasts. We do CD61, which is a marker for megakaryocytes, and we do glycophorin A, which is for the erythroid lineage. So in my previous presentation, I mentioned that glycophorin A will also stain red blood cells, and when you're doing the interpretation of this stain, you have to look at only the nucleated cells because those are the erythroid precursors. Flow cytometry has the benefit of being much faster than the immunohistochemical stains. You get it within an hour or two. And there are different panels depending on the clinical picture and the suspicion. There's, acute leukemia panel in this case. And every case of leukemia is sent to for cytogenetic testing. So we have 2 types, either the conventional or FISH. Conventional karyotyping, and then FISH is the fluorescent and cytohybridization. We also do molecular testing for every case of leukemia, and to detect the different mutations. We have a myeloid gene panel that includes 54 of the most common genes that are mutated in acute myeloid leukemia, and we test those by next-gen. So this is just a reminder of the myeloid lineage. It starts by the myeloblast, which is a large cell with prominent nucleoli, then promyelocyte, which has a lot of granules that are obscuring the nucleus sometimes. It's a large cell. Then a myelocyte, then you start having an indentation in the nucleus. This is the metamyelocyte, and when you have more indentation, that is more than half of the nucleus, or a C-shaped nucleus, it becomes a band, and then when it's segmented, it's a neutrophil. The most important thing about leukemia is that you have to recognize the blast. I think no matter what your specialty, you have to recognize blasts on smears. You never know where you're going to be practicing, and seeing a blast on a blood smear or even CSF or any type of fluid, you have to be able to recognize it. Blasts are usually larger cells. They have open chromatin, so the nucleus chromatin is pale, it's not dark. They have a high NC ratio, to the nuclear to cytoplasmic ratio is high. And they usually have prominent nucleoli. So if you look here, these are prominent nucleoli. Nucleoli in fluid are paler than the rest of the nucleus, so it will actually look paler than the other chromatin within the nucleus. In tissue, the nucleolus is darker than the rest of the nucleus. Okay, so in order to separate myeloblasts from lymphoblasts just by morphology, the only thing that can tell you for sure that this is a myeloblast by morphology is the presence of an hour rod. Otherwise, they are all soft signs, and you shouldn't commit to one type of blast just by looking at it if you don't see an hour rod. So for myeloblasts, you usually have more cytoplasm, and the cytoplasm usually contains granules. Hour rods are just granules that are lined up. Lymphoblasts, on the other hand, usually have scant cytoplasm, more basophilic or bluish cytoplasm, less granules. They have less number of prominent nucleoli. There's something also called blast equivalents. These are cells that are not blasts, but they are included in the blast count. And it's important to know them because if you include them in the blast count, then the blast count might reach 20%, and that you'll be able to call it acute leukemia. So those cells include promonocytes. So promonocytes are one of the most difficult cells to identify. And I'll show you pictures of those in a little bit. Other cells are promyelocytes, and these are considered as blast equivalents only in acute promyelocytic leukemia. And then we have the myeloblasts, the monoblasts, and megakaryoblasts, and the erythroblasts in pure erythrocytic leukemia. All right, so I'm going to talk about the markers of blasts. Generally speaking, they're CD34 positive, but some of the types, they will have CD34 negativity. Some of them will be TDT positive as well. generally speaking, again, the myeloid markers are CD13, 33, and 117. So when the blast is positive for these markers, we go towards acute myeloid leukemia. However, if we see B lymphocytic markers, it's more towards B ALL. And if T lymphocytic markers like CD2, CD3, and CD7, then we think of T ALL. Markers for myeloids are myeloperoxidase, CD13, CD33, CD34, and CD117. So we do these stains to check for myeloids. We do them by IHC, by cytochemistry, and by flow cytometry. So this is an example of a normal bone marrow biopsy. So we have the largest cells are the megakaryocytes. We have these islands of cells that look like dots of ink, and these are erythroids. And then the majority of the background has the myeloids, which include erythroid precursors, mature neutrophils. So you should see maturation in a normal bone marrow. This is myeloperoxidase staining the myeloid lineage. And the intensity differs depending on the maturation of the cell. So the more immature the cell, the more stronger or intense the myeloperoxidase will be. So this is from one of the cases. This is a bone marrow where you have the bone spicules here, and it is definitely hypercellular. You see that the cells extend between the bone. You don't see any adipocytes. And the cells are basically the same. You don't see the trilineage hematopoiesis, which means you should see megakaryocytes, erythroids, and myeloids. Here, it's just one type of cell. It's a large cell with irregular nuclear membrane. The chromatin is pale or open, and sometimes you see prominent nucleoli. So these are all blasts. These are sheets of blasts. And then the next step is to do the markers by IHC and flow to see what type of blasts they are. Just a reminder, because this is important in the classification, monocytes arise from monoblasts, which mature into promonocytes and then into monocytes. And the markers are CD14, 13, 33, 4, HLA-DR. These are examples of IHC and flow markers that we can do to identify monocytes. Alpha naphthyl acetate and butyrate are cytochemical stains that are positive also in monocytes if you need to differentiate them from myeloid cells. Another review for the markers of megakaryocytes, CD61 is the one we usually do in our department, but there are others like CD41, CD31, and 42B. And the markers for erythroids are glycophorin A, and E-cadherin, and hemoglobin A. Glycophorin A, again, stains red blood cells, so you want to evaluate only the nucleated erythroid precursors. E-cadherin has the benefit of only staining the immature erythroids. Then we'll talk about cytochemical stains. These include myeloperoxidase. So myeloperoxidase or MPO you can do by cytochemistry or you can do by IHC. This is specific for myeloid cells, and monoblasts are generally negative. Another cytochemical stain is Sudan black. Sudan black will also stain myeloblasts and will be negative in lymphoblasts and may have occasional gray staining in lymphoblasts. Sorry, having some technical issues. Try to exit the full screen. All right, so I'm going to continue talking about the cytochemical stains. So myeloperoxidase stains the myelocytes, and you can see it has the black granular stain of the cytoplasm, in this case of acute leukemia. Other cytochemical stains include NSE and or nonspecific esterase. These are stains that are specific for the monocytic lineage, including monoblasts. So this is nonspecific esterase staining in acute monoblastic leukemia. You can see that the cells that are monocytic in lineage are staining with this orange stain, and the rest of the cells are not going to show because they're negative, like this neutrophil here. So coming to the WHO classification of acute myeloid leukemia, the WHO classifies acute myeloid leukemia into acute myeloid leukemia with recurrent genetic abnormalities, acute myeloid leukemia with myelodysplasia-related changes, therapy-related acute myeloid leukemia, acute myeloid leukemia not otherwise specified, myeloid sarcoma, and myeloid proliferations associated with Down syndrome. We're basically going to be talking about the first four types. And let's start with acute myeloid leukemia with recurrent genetic abnormalities. So in this case, you have acute myeloid leukemia, and then you send for cytogenetics, and you have a known translocation that is associated with acute myeloid leukemia. There are many types, but here you have to know the translocation and what it causes, like the fusion of the genes or the mutations that occur. So for example, translocation 821 is a RUNX1T1 mutation, and then there's also inversion 16 or translocation 16. There is translocation 1517 or acute promyelocytic leukemia, PML-RARA. And we know that the first three types are known to have less than 20% blasts. I mean that you can diagnose acute myeloid leukemia with these translocations, even if you have less than 20% blasts. Other types are translocation 911, translocation 69, inversion 3 or translocation 3, translocation 122, and then we have the newer AML with BCR-ABL1, AML with mutated NPM1, and AML with mutated CEBPA. So we'll start one by one. Let's start with translocation 821. So for each one of these types of AML, you need to know a couple of keywords that will tell you what's characteristic of this type of leukemia. Translocation 821 is known to have neutrophilic maturation. So it is reminiscent of acute myeloblastic leukemia with maturation, or acute myeloid leukemia with maturation. So I'm sorry, it's very slow. Okay. I'm going to exit the full screen. Apparently it's slower when it's full screen. Again, for the translocation 821, you have a neutrophilic maturation. And also they're characterized by having these perinuclear clearing and salmon-colored globules. That's in translocation 821. Again, they have a lot of neutrophils because they have maturation, and they're frequent hour rods as well. When you do markers for these leukemias, they are positive for the myeloid markers 13, 33, 34, HLA-DR, and myeloperoxidase. And this is one of the most common types of acute myeloid leukemia. And this is a board question. What type of acute myeloid leukemia is usually showing lymphoid markers like CD19, PAX5, CD79A, which are B-cell lymphoid markers? It's this type of leukemia, translocation 821. And since you have maturation, then you're going to see markers of maturation, including CD15 and CD65. Translocation 821 usually have a favorable prognosis unless there's an additional or secondary abnormality, including a KIT mutation. Then it's not so favorable. They're associated with mastocytosis and different mast cell diseases. They can present as a myeloid sarcoma. So the first time you see the patient, the patient might just have this mass or mass forming lesion in the tissue, which is composed of blasts. Translocation 821 involves the RUNX1, which encodes for the CBF alpha or the core binding factor alpha. And it's commonly, the gene that is commonly mutated in this type of AML is ASXL2. And we have that by NextGen. The second type of acute myeloid leukemia, and we're still in the category of acute myeloid leukemia with recurrent genetic aberrations or abnormalities, is AML with inversion 16 or translocation 1616. This is another type of acute myeloid leukemia where you don't need 20% to call it leukemia. If you have less than 20% blasts, you can still call it leukemia if it has this translocation. And this translocation causes it forms the CBFB MYH11, which is the core binding factor beta and the myosin heavy chain 11. So this is the chromosome 16. You get a portion of the P and the Q arms, and they are kind of translocated or inverted. And it's the inversion C. You have to note that for this type of acute leukemia, there is a monocytic and granulocytic differentiation, so it looks like a myelomonocytic picture. Some of the blasts look like myeloblasts, some look like monocytic or have a monocytic differentiation. The white blood cell count in this type of leukemia is higher than translocation 821. And it's characterized by having abnormal eosinophils in the bone marrow. So again, we said that for the translocation 821, there's neutrophilic maturation, there's salmon globules or perinuclear clearing. And in this case, you have normal eosinophils, and there's a monocytic and granulocytic differentiation. So this is what I mean by eosinophilic precursors that are seen that are actually abnormal in inversion 16 or translocation 1616. These are abnormal eosinophilic precursors. They have a lot of purple or violet colored granules in their cytoplasm that might also obscure the nucleus. So this is characteristic of this type of leukemia. The blasts can show different types of markers, including high CD34 and CD117 expression in some of the blasts, and then more monocytic differentiation or markers in others. And chloroacetate esterase by cytochemistry will stain some of these abnormal eosinophils. Again, this is like translocation 821. This is another acute myeloid leukemia that has a favorable prognosis if you don't have any other abnormalities. But if you have a KIT mutation or a FLT3 mutation, then it becomes unfavorable. There's an association with trisomy 22. And unlike translocation 821, ASXL2 mutations here are uncommon. And this is just an example of a flow cytometry showing the myeloblasts. So here in this flow cytometry is basically, it detects different markers on each type of cells. And you can gate on whatever group of cells you would like. In this case, the blasts are in green. And for myeloperoxidase here, they're positive. They're positive for CD34, and they're also positive for CD117. They're positive for CD13. They're positive for CD33 and for HLA-DR, so that tells you they're myeloblasts. And then we do more markers to detect what type of, what else do they express. The third type of acute myeloid leukemia, still in the group of acute myeloid leukemia with recurrent genetic aberrations, is the acute promyelocytic leukemia with PML-RARA. This type is the third type of acute myeloid leukemia that can be diagnosed without 20% blasts. And this is also when the only time when the promyelocytes are considered in the blast count or included in the blast count. This is an emergency and has to be recognized immediately because the patient is prone to DIC or disseminated intravascular coagulopathy and could be life-threatening, although with treatment it has a very favorable prognosis. the patient might have profound thrombocytopenia because of the DIC. There are two variants of acute promyelocytic leukemia. There's hypergranular variant and microgranular variant. The hypergranular is more common. And from the name, the hypergranular has more granules. The microgranular variant has a higher white blood cell count. These types of leukemias usually are negative for HLA-DR and CD34. So promyelocytes normally are negative for CD34 and HLA-DR. So in this type of leukemia, this is characterized by negative HLA-DR and CD34. So for example, if they show you on a board exam flow cytometry sheet with negative HLA-DR and CD34 and ask you what type of acute myeloid leukemia this might be, so you should include acute promyelocytic leukemia. Again, the hypergranular variant has a lot of granules, many hour rods. It's strongly positive for myeloperoxidase. The microgranular variant has less granules, and the nuclei are characterized by being bilobed or butterfly in shape, and it has a higher white blood cell count. So this is the hypergranular variant. As you can see, there are many, many granules in the cytoplasm and a lot of hour rods. And this is the microgranular variant. Here are the cells. These are all blasts, but the cells are kind of bilobed and, again, butterfly in shape. They have some granules, but not that much in the cytoplasm. And the differential diagnosis here becomes with any monocytic differentiation. And the easiest way to do that is to do the markers. These are myeloblasts or promyelocytes, so the myeloid lineage. So they will stay positive with myeloperoxidase, but monocytes will be or should be negative. And then you can do the NSE and other stains for the monocytes to confirm. This is an example of a FISH test. This is in this case of APL. So let's say, so we know we have 2 chromosomes in each cell. This is one cell. This is showing the chromosome 15, and this is chromosome 17. So when you have a translocation 15, 17, you're going to see this yellow color, which means there's fusion between the PML and RARA on both chromosomes. So normally you should have 2 of each, but when they fuse, you're going to start seeing this yellow color. So this is positive. Translocation 15-17 is characteristic for PML-RARA, and it has a favorable prognosis because it responds to treatment. And the treatment is tretinoin or all-trans retinoic acid. There are other types included, newer translocations, including 1117, 517, 1117 with a different gene mutation or fusion, and translocation 1717. We have to know that some of these types are actually do not respond to treatment, so they're resistant to this treatment. And that's the importance of doing the cytogenetics. Again, this is an emergency. You have to be able to recognize these promyelocytes on smears so you can give the patient the treatment immediately. We're still in the category of AML with recurrent genetic abnormalities. Now we're talking about translocation 911. This is more common in children, and you have to know it shows monoblasts and promonocytes. Again, this also can present as DIC, not as common as APL though, or as a myeloid sarcoma, and has an intermediate prognosis. So for each type of AML, just know a couple of keywords that will help you remember it. So for 911, usually children, monoblast or promonocyte, and intermediate prognosis. Next is AML with translocation 6-9. Here, the white blood cells are generally lower than other types of AML. And it's important to know that translocation 6-9 is associated with vasophilia and dysplasia. So, and this one has a poor prognosis. So remember vasophilia and dysplasia with translocation 6-9. AML with inversion 3 or translocation 3. This one also is associated with dysplasia, actually multi-lineage dysplasia, especially in the megakaryocytes. And that's why sometimes you have usually you have thrombocytopenia, but you might also have thrombocytosis, but you see dysplasia and with this type of acute myeloid leukemia. So here the question is, if I see dysplasia, do I call it AML with myelodysplassia related changes, or do I call it AML with inversion 3? If you have the translocation, then this takes precedence. It is AML with inversion 3. And I'll talk about the different types and which takes precedence over the other type. This is another AML that has a poor prognosis. And then we have AML that is megakaryocytic, 122. This usually occurs in infants, and they have a megakaryocytic morphology. So the blast will have these cytoplasmic projections or pseudopods or blebs, and I'll show you pictures of that. And they're also positive for the megakaryocytic markers like CD61, 41, or 42B. This has a favorable prognosis with aggressive chemotherapy. So 122 is megakaryocytic, occurs in infants, and positive for megakaryocytic markers. The last types of included in this category of AML with recurrent genetic aberrations include AML with BCR-ABL1. This is one of the provisional entities included in the new WHO 2016. In this case, it doesn't fit any other type of acute myeloid leukemia, but it has a BCR-ABL1 translocation 922. But this one has less mesophilia and splenomegaly than what you see in chronic myelogenous leukemia. We know this is the translocation usually seen in CML. Another type is AML with mutated NPM1. Some institutions have NPM1 as an IHC stain, immunohistochemical stain. When you do the stain, it will stain more than 2 types of lineages, like myelomonocytic lineages, and it doesn't fit any other type of AML. We also have AML with mutated CEBPA and AML with mutated RENX1. So back to our classification, we talked about AML with recurrent genetic abnormalities, and those types that we mentioned are just in that group. Now we're going to talk about excuse me, AML with myelodysplasia-related changes and therapy-related AML. So AML with myelodysplasia-related changes, you can't call it AML with myelodysplasia-related changes without having these criteria, 3 criteria. So just because you see some dysplasia doesn't make it AML with MRC. You have to have first more than 20% blast in the peripheral blood or bone marrow, otherwise it's not an acute leukemia in this case. And I'll skip number 2. Number 3 says that you have to have absence of prior history of treatment or radiation, meaning that there is no history of therapy for any types of cancers, including hematological cancers or disorders. Otherwise, it will be called a therapy-related AML. And also, you can't have, it cannot fit any of the types that we mentioned before, the AMLs with recurrent genetic abnormalities, okay? So absence of the genetic abnormalities, absence of history of treatment, and then more than 20% less with any of the following. So you have to have myelodysplasia. So you see the dysplasia not only in one lineage, but 2 or more lineages, and it has to be more than 50% of the lineage. So in MDS, when we're diagnosing MDS, we have to have it in more than 10% of each lineage. But here in AML-MRC, it has to be more than 50%, and it's in more than 2 lineages. Or you might have a history of documented history of MDS or myelodysplastic syndrome, or myelodysplastic syndrome / myeloproliferative neoplasm. Or you might have one of the cytogenetic abnormalities that are commonly seen in MDS or MDS-related cytogenetic abnormalities, including deletion 5q or monosomy 5 or monosomy 7, and other types. So if you don't have these criteria, you can't call it AML-MRC. This is just a reminder of the features of dysplasia that you might see in the different lineages. For example, this is a neutrophil. It's in the peripheral blood, but the cytoplasm doesn't show many granules, so it's hypogranular. That's a sign of dysplasia. This is another supposed to be neutrophil, also in the peripheral blood. But as you can see, the nucleus is not segmented. It's hyposegmented. That's another sign of dysplasia in the myeloids. This is from a bone marrow aspirate, and you can see the erythroids here showing budding and nuclear irregularity. This is a sign of dysplasia in the erythroids. And the best to see, to use to see the dysplasia in the megakaryocytic lineage is the bone marrow biopsy. You can see a hypolobated megakaryocyte. The nucleus is supposed to be multilobated, but it's hypolobated. Or you might see clusters of megakaryocytes. That's another sign of dysplasia as well. And remember, you have to have the dysplasia in more than 50% of the lineage, in more than two or more lineages, to be able to call it AML with myelodysplasia-related changes. So again, if you have the translocation, you're going to call it AML with recurrent genetic abnormalities. If there's history of therapy, it's going to be a therapy-related AML. And if it meets the criteria for MRC, then that's what you're going to call it. So next is the therapy-related AML. Basically, these are, the patient has been diagnosed with a cancer, a solid organ tumor, or a hematological cancer or disorder, and has been treated with chemotherapy or radiation, and now developed AML. There are two main categories. There's the alkylating agents and radiation related, and the topoisomerase II inhibitor related. These are the two main types of therapy related AML. So for the alkylating agents related AML, this usually occurs 5 to 6 years after the treatment. And usually it appears as a therapy-related myelodysplastic syndrome rather than a therapy-related acute myeloid leukemia. But when it is an acute myeloid leukemia, it's usually an acute myelomonocytic leukemia, and the prognosis is poor. On the other hand, the topoisomerase II inhibitor-related AML occurs much earlier, 1 to 3 years. I've seen it less than 1 year. And this is when patients are treated with these type of treatments or chemotherapy like etoposide and doxorubicin. And these patients usually develop AML more than getting therapy-related MDS. And they're associated with MLL mutations. Okay, so let's say you have a patient with acute myeloid leukemia, and they are showing features of different types of the WHO classification. So which one are you going to fit, or what are you going to call it? Again, if you have a recurrent genetic abnormality, that's what you're going to call it. Okay. If the next is, if you have a history of treatment, then it's therapy-related AML. So after you exclude these, and you see signs of dysplasia, or it fits the criteria for myelodysplasia-related changes, then that's what you're going to call it. And if it doesn't have any of these, then it's AML NOS, or not otherwise specified. So now we're going to talk about AML NOS. Acute myeloid leukemia not otherwise specified. This is the one that we that used to have the M0 to M7. We don't use that anymore. These are basically, we are differentiating them depending on the morphology and the markers. So just go by the name of the AML and you know what it means. So AML with minimal differentiation means that the blasts do not look like myeloblasts. You can't tell if they're myeloblasts or lymphoblasts or what type of blast. And also when you do cytochemistry, they're still negative. You can't tell it's a myeloblast. So MPO will be negative by cytochemistry. It might be positive by HCR flow though. So here you see all the blasts, but they don't show our rods, and by cytochemistry, they're negative for MPO, Sudan black, which is another cytochemical stain that's positive in the myeloids. Next is AML without maturation. Basically here you have blasts, and you don't see a lot of maturation, so you don't see neutrophils, eosinophils, and other mature cells. Most of what you see are the blasts only. You can see our rods in this case. And the markers for maturation are negative. So for neutrophilic maturation, CD15 and CD65, these markers are negative. And for monocytic maturation, CD14, for example, is negative. Next is AML with maturation. In this case, you do see mature cells. You have more than 20% blasts, and more than 10% of the bone marrow cells are mature cells of the granulocytic lineage. So you see a lot of neutrophils, eosinophils, they have to be more than 10%. But the monocytes are less than 20%. Otherwise, it fits another category of AML. So in this case, you have maturation, you have more than 10% mature cells of the granulocytic lineage, and less than 20% monocytic cells. Next is acute myelomonocytic leukemia. Basically, you have both. You have myelo or neutrophilic or granulocytic lineage cells, and you have monocytic cells. And of course, you have more than 20% blasts. But each type of lineage or each type of cell is also constitutes more than 20% of the bone marrow cell count. Sometimes you might see cells that show markers of both. So they will have dual positive cells with a marker like myeloperoxidase, which is myeloid, and NSE, which is monocytic, and the same cell. Acute monoblastic leukemia or acute monocytic. So this is the next type of leukemias, and now we're talking about AML, NOS, or not otherwise specified. In this case, you have more than 20% blasts, but the predominant lineage is monocytic. More than 80% of the cells are monocytic, either monoblasts, promonocytes, or monocytes. So they're called acute monoblastic leukemia when most of the cells, more than 80%, are monoblasts. And these are usually, I should say, most of the blasts are monoblasts, and these are usually younger patients. And you call it acute monocytic leukemia when most of the cells are monocytes and promonocytes. And you don't see a lot of monoblasts. So this is acute monocytic leukemia. So these are monoblasts. Monoblasts are usually larger. They have more abundant cytoplasm. They have less granules in the cytoplasm. They might have prominent nucleoli. And the promonocytes, again, they're hard to see, but they look like monocytes, but they have nuclei that are folded and curved, and they usually have prominent nucleoli, multiple prominent nucleoli. And again, these are blast equivalents, so they are counted within the blast count. So these are monoblasts, and these are promonocytes. The markers, again, basically you see markers for monoblasts and promonocytes. Markers include CD13 and 33. These are more myeloid, and then CD14, 11B, 11C, and 64, more monocytic markers. You might see hemophagocytosis in this type of acute myeloid leukemia. Hemophagocytosis means the cells engulf red blood cells. And this is associated with the translocation 816. This is not one of the AMLs with recurrent genetic abnormalities, but it's a known association with acute monoblastic and monocytic leukemia. Next is pure erythroid leukemia. So this is when you have the erythroid lineage constitutes more than 80% of the bone marrow cells. This is called pure erythroid leukemia, and it's positive for the erythroid markers. We used to have something called erythroleukemia, where we used to count the number of myeloid precursors or myeloblasts to the number of erythroid precursors and try to fit it into this category, but we don't have that anymore in the new WHO classification. Right now, if you have erythroids and you have the blasts that are less than 20%, in these cases you usually see dysplasia, then you call it myelodysplastic syndrome with excess blasts. But if the blasts are more than 20%, it's an acute myeloid leukemia with myelodysplasia-related changes. So there's nothing called erythroid leukemia anymore. Again, if you see more than 80% of the bone marrow cells being erythroid, it's a pure erythroid leukemia. The cells in this case usually have vacuoles in the cytoplasm, and these vacuoles might join up and coalesce together and form one big vacuole. You see megaloblastoid changes in the erythroid lineage, and they are positive for the erythroid markers like glycophorin A, ecadherin, and they'll be negative for other markers like MPO, CD41 and 61, which are megakaryocytic. CD117 or c-KIT actually stains erythroblasts. It will show a weak membranous or cytoplasmic staining, and these types of leukemias have a rapid clinical course or a poor prognosis. Okay, sorry. Acute megakaryblastic leukemia. I apologize. It's too early in the morning. It's 7 a.m. right now, but it's okay. Acute megakaryblastic leukemia. This one has acute leukemia with more than 50% of the blasts have a megakaryocytic, are of the megakaryocytic lineage. So again, when they're megakaryoblast, you see these cytoplasmic projections or pseudopods or blebs. That's characteristic of the megakaryocytic lineage blasts. And there's a known association with germ cell tumors like seminomas, embryonal carcinomas, yolk sac tumors, and others. So the megakaryoplasts again have these blebs or pseudopods, and they're positive for the megakaryocytic markers, including CD41, CD61, and others. When you're counting the peripheral smear, you might see some megakaryblastic fragments and micromegs in the peripheral smear. You shouldn't count the micromegs as part of the blasts because they are not blasts. And the bone marrow biopsy might show fibrosis. So this is one of the AMLs that might look like a metastatic carcinoma because you see fibrosis and then you see these large cells. But this is acute megakaryblastic leukemia, and when you do the stains, you see it. Again, the 5 essential stains or the stains that we start with when we get any bone marrow biopsy are CD61, myeloperoxidase, CD34, CD117, and glycophorin A. This is what we do in our institution. These patients with acute megakaryblastic leukemia have usually present with thrombocytopenia and rarely with thrombocytosis. So again, what are you going to call the, how would you fit it into the different types of leukemia? If you have one of the translocations that are included in the recurrent genetic abnormalities, then you call it acute myeloid leukemia with recurrent genetic abnormality, and you list the translocation there. If you have history of treatment, then it is a therapy-related AML from a cancer, from chemotherapy or radiation. And again, we have 2 types. We have topoisomerase 2, which usually occurs earlier, 1 to 3 years after the treatment, and the alkylating agents, which occur later on. If you don't have any of these and you see signs of dysplasia, you can call it AML with myelodysplasia-related changes only if there is no history of therapy and no recurrent genetic abnormalities. And also, you have more than 20% blasts, and then you have to have either signs of dysplasia in more than 50% of 2 or more lineages, or a documented MDS, history of the MDS or MDS/MPN, or one of the recurrent or the genetic abnormalities that are known to be associated with MDS. And if you don't have any of that, you call it AML NOS, not otherwise specified, and then you go by the morphology and by the markers to fit it into which type of acute myeloid leukemia that we just talked about. Generally speaking, for risk stratification, if you don't have a lot of cytogenetic abnormalities or there's an NPM1 mutation, that's generally a favorable prognosis, or the wild type of FLT3. Wild type means it's normal, it's not mutated. So the wild type in anything is good. Or there could be an adverse effect if you have complex cytogenetics, and that's usually the case. You have different types of cytogenetics, not just one. Or a P53, usually it's a bad prognosis, or a FLT3 is usually a bad prognosis as well, generally speaking. So again, the classification included AML with recurrent genetic abnormalities. Those are the ones that had the recurrent translocations, and 3 of them, we didn't need 20% blast to call it AML. Which one are those? The translocation 821, the translocation 1616 or inversion 16, and the 1517 translocation or the acute promyelocytic leukemia. The others, we need 20% blast so far. They're still studying them because there's debate about that. And then we had the AML with myelodysplasia-related changes, and it has to fit the certain criteria. Otherwise, you can't call it just by seeing some dysplasia in the lineages. Then we had the therapy-related AML. We had AML/ NOS or not otherwise specified. And then myeloid sarcoma and myeloid proliferations associated with Down syndrome. I don't think we have time to talk about that. But myeloid sarcoma is basically having a tissue-based lesion with blasts. So myeloblasts that form a mass, and they're positive for the myeloid markers. And they used to call them chloromas because grossly they look green. And they usually show also immature or abnormal eosinophils in the lesion. You need to do MPO, CD34, and CD68 is also another stain for myeloid sarcoma. Myeloid proliferations associated with Down syndrome, these are usually megakaryocytic, and I don't think we have time to talk about that today, but thank you very much. I know it's a lot of information in one lecture. This is mainly an overview, so I'll leave you the presentation so you can go back and look at it again. And thank you, I appreciate. Thank you.
Thank you very much, Dr. Nagla.
Thank you. I
It
hope
was a very comprehensive and extensive lecture. It's nice to have the slides to see it more and more.
Thank you very much. And I'll leave the presentation on YouTube for anybody who wasn't here.
Thank you so much, Dr. Nagla. Annie, we thank you so very much. And next we have Dr. Mohamed Hegazi. And what is Dr. Mohamed, are you connected? Can we hear you?
Yes.
Okay,
Yes,
great.
let me just.
So Dr. Mohamed Hegazi is a graduate of Mansoura University. He did his residency at Jersey Shore University Hospital and his fellowship at University of Louisville. He's board certified in internal medicine, medical oncology, and hematology. And he's currently an assistant professor of bone marrow transplant at University of Louisville, Brown Cancer Center, Louisville. اتفضل دكتور.
السلام عليكم. سؤال سريع، ازاي ممكن ادخل البرزنتيشن على السكرين؟
Yes, Dr. Neg, what's your question again? Sorry.
How do you get the PowerPoint presentation on the screen instead of my picture?
Screen. Okay, so hover over the bottom, and you should find the option to share screen to share. Oh wait, are you already sharing? You are already sharing. That's what you mean.
Is it okay?
How about maybe, like, you should be able to use the PowerPoint the same way.
Is it? You can see it now.
Yes.
Okay. Alright, السلام عليكم. شكرا جزيلا على الانفيتيشن ديت. سامحوني ان صوتي رايح شويه، عادة صوتي عالي بس الظاهر النهارده حظي وحش ان مش عارف تسمعوني كويس. فلو مش فاهمين please ask me to repeat and I'll talk and I'll repeat whatever you want. Okay. So today we're going to talk about acute myeloid leukemia, current standards in terms of therapy and future approaches. طبعا it's great to talk about acute myeloid leukemia at this day and age, but it's also even more amazing to have it after a beautiful pathologist presentation. It makes it so easy, so I can bypass all the stuff that smarter people like those pathologists can understand, and I won't have to talk about. So I'll go directly into the therapy-related, the therapy-related topics. Disclosure, I have no conflict of interest. There is no financial conflict between any of these presented data. I might use some off-label discussions based on research that has not been approved yet. I'm going to talk a little bit about statistics, and then I'll go right to risk stratification and then go to treatment. So because Dr. Salem has done a wonderful cover on all the other pathology-related topics. So statistically, acute myeloid leukemia is not the most common cancer, of course. In the United States, it represents only about 1% of the newly diagnosed cancer. However, it represents about 2% of deaths of all cancers. And what's striking is the survival. The survival here is about in 5 years, it's only 27%. And that's only until 2014. A lot of things happened since then. This is in Kentucky where I practice. Leukemia is more common and it's it's deadlier. So leukemia represents almost 6% of cancers here, and it's almost 10% of the cancer-related death. AML is known to be a disease of the elderly, so even though it's present at a young age, it's extremely uncommon when you compare it to the latter decades of our life. As Dr. Salem presented, there is a multitude of mutations and that occur in AML. Some of them happen separately, alone, but most of the time, there's at least an average of 3 mutations that happens in each AML patient. And you can see here in this diagram that sometimes you'll have something like NPM1 that has all these possibly associated mutations. So you have to be careful if you call an NPM1 AML patient favorable risk. It really is not if the patient has an unfavorable high allelic ratio of something like FLT3. So we have to always look at all the possible mutations, and we run a next gene sequencing generally on every newly diagnosed patient, and I think that's the future. So to cut to the chase and use what I use to break down the patients based on risk, we use the ELN 2017 categories to break it down between good, intermediate, and poor. And different from the WHO criteria, we're incorporating also molecular markers so we can risk stratify them based on such. So as Dr. Salem mentioned, translocation 1517, translocation 821, inversion 16, or any of the core binding factor abnormalities are typically associated with favorable prognosis. Also, if you do not have any of these mutations, but you have a mutated NPM1 without the presence of FLT3, which is another molecular finding that's known to be a poor prognostic marker, if it's absent, meaning wild type, or if it's present at a low allelic ratio, meaning the ratio between the FLT3 mutated and the unmutated is less than 0.5, then you might still consider those people a good risk. And then the biallelic CEBPA are still considered good risk. Intermediate risk is when the mutations become a little vague. We don't know if that's a good thing or it's a bad thing. It's kind of in the middle. Translocation 911 is put currently in the intermediate risk. However, what I've seen, usually those with the MLL rearrangement do not do very well. Those who don't have any mutation are intermediate risk. So absence of mutation, it's not actually a good risk. If you don't have any mutations in AML, that doesn't mean that you're in good risk. Some of those mutations make you better risk than without any. NPM1 mutation, something that's typically you would think as a mutated, when it's mutated, it's a good marker. Those actually, if it's associated with a high allelic ratio of FLT3, then you're talking about a intermediate risk patient. If you don't have a wild type NPM1, meaning it's absent, but you have a low allelic ratio of FLT3 or wild type FLT3, that means they are also intermediate risk. Think about the molecular markers that are now coming strongly that Dr. Salem mentioned, RUNX1, ASXL1, all those, if they are if they are in part of the core binding factor leukemias like the 821 version 16, if they are not there, these are also considered poor prognostic markers alone. However, if they're with those mutations, that might trump the fact and make it a better prognostic feature. Remember, deletion 5q in acute leukemia is bad compared to deletion 5q in myelodysplastic syndrome. So if you have the 5q syndrome in MDS, you might treat them with lenalidomide and they live a good life. they might survive years and years. However, if this is happening in AML, it's not a good. And always, anything that has to do with chromosome 17 is bad. Deletion 17 is bad. And deletion 17 and the mutation in TP53 are generally correlated most of the time. And the presence of TP53 is a bad prognostic marker across the board in whatever malignancy you're talking about in hematology. The presence of BCR-ABL1 is also. Any complex karyotype is considered. The more mutations you have, the worse the prognosis. The more mutations you have, worse the prognosis. That's pretty much simple as that. So please let me know if I'm talking too fast or if you don't understand what I'm saying, because I know my voice is not the best today. All right, so this is pretty much the risk stratification, and based on this risk stratification, the reason why I'm using this one is because it plays a role in my therapy today, in what we use, in what we treat. All right, just a simple introduction to what is treatment in AML. We have induction, consolidation. In induction, you usually have heavy-duty chemotherapy, prolonged cytopenias. Generally, the most common regimen you use is something called 7+3. You all might be familiar with anthracyclines plus Ara-C. Other centers use, their standard is different. Like some would use CLAG-M, which is a cladribine-based regimen with Ara-C, G-CSF, and mitoxantrone, and some others use a combination of other therapies. However, CPX-351, which we'll talk about a little later, is pretty much similar to 7+3. However, it's provided in a liposomal form. I'll show you how it's delivered now. It's basically an old drug in a new look. Consolidation is generally to continue the induced remission, and the goal of it in general is to either complete the therapy or bridge to transplant, depend on if that's what you want or not. But generally speaking, you either give 3 cycles of consolidation or you go for, after 1 cycle of consolidation, to transplant. We don't take too long to take, we don't wait too long to take them to transplant after consolidation, if that's what we want to do. And AML, or I'm sorry, it's supposed to be APML, or M3, acute promyelocytic leukemia. That's the disease that soon will not be one of the should not be called even an acute myelocytic leukemia altogether, because it's completely treated differently. And I'll cover this one very quickly since it's not the main point of my discussion today. APL has the best outcome when treated. At the same time, APL has the worst outcome without treatment. Those people die very quickly if you don't identify this illness and treat it. Generally speaking, we use all-transretinoic acid when we suspect it, not even when we know that it is. When we suspect it, we give ATRA until we get the cytogenetics showing the translocation 1517 or PML-RARA on the molecular testing. As Dr. Salem mentioned, DIC is a big concern in acute promyelocytic leukemia, more than in other leukemias. However, it can present in any leukemia, and we sometimes will need to give them a lot of cryoprecipitates and other blood products to maintain them out of a disseminated intravascular coagulopathy. Remember, it's usually those type of illnesses that are so critical, the ones that you can have a very good shot at saving their life, but they can die very fast if you don't treat them appropriately. These are the ones that you pay critical attention. And generally speaking, where we practice, anybody in the community practice, if they get an APL, it comes to us because we want to make sure they get the treatment they need at the tertiary care centers. The treatment is quite straightforward in APL. It just takes a long time to achieve your goals. In induction, you break them down to low risk and high risk, which is simply based on white count. That's all. It's all very straightforward. Once you have identified it based on the phenotype that Dr. Salem mentioned earlier, but basically, most importantly, when you have that HLA-DR negative as well as CD34 negative, and you have a positive CD33, and you're thinking this is an acute myeloid leukemia and with promyelocytic leukemia, you look at the white count. That's all. Look at the white count on the CBC. If it's less than 10,000, that's called low risk. And you treat it with all-transretinoic acid. It's an oral drug. And ATO, arsenic trioxide. It's IV, and it's given once a day. Versus if it's high risk. If it's high risk, it's we need to use anthracyclines in the component, meaning ATRA plus anthracyclines, and that's the regimen that we use. You might have people using plus minus still ATO in induction. This is we're talking about the initial treatment as they walk through the door, but we leave that for consolidation. So we keep that for consolidation here. There's a couple of studies, MD Anderson and the APML4. Each one of them has its own regimen. And in our mind, if we achieve morphologic remission with ATRA, anthracycline, we should leave the ATO for later and use it in consolidation. People who have poor cardiac function or have prolonged QT, you have to be quite concerned about those. So generally speaking, you, and maybe I should clean this up, but generally speaking, you get rid of the, you try to avoid anthracyclines in people who have cardiac dysfunction, especially in such a curable disease that you might be able to achieve with arsenic trioxide. People with a prolonged QT interval, generally speaking, you would try to avoid arsenic trioxide. So maybe you would use gemtuzumab ozogamicin, which is an anti-CD33 that I will talk about later. In acute promyelocytic leukemia, generally, your goal of induction is morphologic complete remission, meaning I'm not trying to get rid of translocation 1517. So when I do the bone marrow biopsy at day 30 or day 35 post induction, I'm not looking to see that I've gotten rid of that PML RARA marker. My goal is to just see that the blasts are gone down, less than 5%. That's all. Because the goal of consolidation is to achieve molecular CR. So you get to molecular CR, and the consolidation in acute promyelocytic leukemia is a prolonged therapy. However, it has excellent outcomes. And we use the Lococo protocol for that, which basically alternating ATO and arsenic trioxide and all-transretinoic acid during the period of consolidation. Just remember that APL, despite it has a great outcome, it still can relapse. And we break it down to two animals completely different. If they had if they have a relapse less than 6 months from completion of therapy, and if they have seen ATRA and ATO, then we are going to use an anthracycline-based regimen and generally treat it as AML. However, if they have not, for some reason, seen ATRA or ATO, then we will come with a hybrid therapy for them. Generally speaking, APL is CD33 positive, so using an anti-CD33 is a good thing to consolidate your treatment. CD33 antibody like gemtuzumab ozogamicin is known to be better, more efficacious in those who have good risk disease compared to high risk disease in AML. However, if the relapse happened more than 6 months, you can just do the same thing again. Just use the same treatment. Quickly, supportive care, make sure when you're giving anybody arsenic trioxide to keep an eye on their QT interval, because it prolongs the QT and then it predisposes you to all these torsade de poids and all those other cardiac arrhythmias that can happen. So once it goes, the QT interval is beyond 500, you need to avoid any QT prolonging agent, and sometimes might even hold therapy. Because of ATO is so dependent, it can cause that, we have to make sure our electrolytes are at good range, meaning we keep the potassium at 4.0 and the magnesium about 1.8. I generally tell them just keep it above 2. Magnesium doesn't hurt. Remember that arsenic trioxide, as well as ATRA, all-transretinoic acid, are differentiating agents. And what does that mean? It means it helps the promyelocyte, the leukemia cell, to actually differentiate into a normal cell, and that's how it became so successful. You're actually not just killing the cell, you're actually helping it proceed to later stages and not be a leukemic cell anymore. However, same as when you unleash a teenager to run in the streets and do whatever they feel like doing, those guys can get in trouble. So the cells can, once they differentiate, they have this syndrome. It's called differentiation syndrome. They start releasing cytokines. So it's a cytokine storm that looks like sepsis. So they can develop fevers, shortness of breath, blood pressure can drop, they leak, they have some sort of a capillary leak syndrome. And generally, this can be treated with steroids. You can use dexamethasone 10 milligrams BID, and in high-risk patients, the use of dexamethasone can be worth it. In high-risk patients, you use it prophylactically. You give the Decadron 10 milligrams BID just to avoid going through this sepsis-like picture that can be deadly if you don't turn around quickly. Do not use G-CSF at all during the induction. Make sure, because it has not been proven to help at all, and there's a concern of it's harming. So unless you have a life-threatening infection and the counts are with a prolonged cytopenias, and you want to have some neutrophils that would make you feel better about it, then maybe. But generally, there is no evidence that helps. And of course, tumor lysis syndrome prophylaxis is a very important. Is a very important thing to keep. So you need to have them aggressively hydrated on allopurinol and monitor their uric acid and all their electrolytes. And if the level goes beyond a certain level, you might have to use respiracase to correct it and protect the kidneys from falling apart. That's pretty much APL. It's an easy discussion that I generally glance over, but it's its own presentation that can take a longer time if we were just focused on it. But for now, I think that's enough. Just always remember the low risk and the high risk. And the low risk is pretty much just a non-chemo target differentiating agents. Now, this is a wonderful day and age to talk about AML. AML was more or less a desert out of any kind of approved drugs until 2017. So 40 years ago, 7+3 was the standard, was found to be the standard of care, the standard of care in AML. However, in early 2000, gemtuzumab ozogamicin was approved in an accelerated approval, and it lost its approval due to liver toxicity. And since then, there was no new drugs at all. No acute myeloid leukemia drugs approved until 2017. Suddenly, there was a flourishing expansion of approvals. And this is all the approvals in malignant hematology in 2017. And I use 2017 because it's a really, really overwhelming approval rate. So midostaurin is a FLT3 inhibitor that was approved in FLT3 AML positive patients. We'll talk about it later. Also, gemtuzumab ozogamicin came back to life. The CD33 antibody came back to life and was approved on a different dosing schedule. So the schedule for gemtuzumab ozogamicin was changed from 2 large doses, or 1 large dose from the approval in 2000, to 3 small doses. So the approval came now. They think this lowers the toxicity. I'm personally biased against it because I haven't seen any good outcome from it with the new dosing, so I don't think it helps. And then you have inacitinib, which is an IDH2 antibody or inhibitor. We'll talk about it later, and this was approved in relapsed refractory AML who are found to have IDH mutation. And last but not least, CPX-351 or liposomal daunorubicin cytarabine was approved for therapy-related AML as well as AML with myelodysplastic features or antecedent MPN. So wonderful year, lots of drugs added, and actually that plays a big role now in the way we treat it. And this is just a quick picture of an approach that how you break them down to the favorable, intermediate, as well as adverse risk. Always, as in any academic environment, if you have a clinical trial, by all means, go for it. That's the way to go in AML. However, if you don't, or this patient doesn't fit it, then you break them down into those. And depending on favorable risk, you will see that now our standard has incorporated a CD33 antibody plus 7 and 3, and in intermediate risk, the FLT3 status plays a big role. And then the presence of therapy-related AML or MDS related, AML with MDS features is also a component. And as I mentioned a little earlier, the utilization of IDH inhibitors has appeared to be of significance. So again, this is a reiteration in a different way. Generally speaking, clinical trial, patient fits, go for it. Favorable risk, patient who has core binding factor, acute myeloid leukemia, or have one of the molecular markers associated with good outcome, like biallelic CEBPA or NPM1 mutated with low allelic ratio of FLT3, you would typically use 7+3 or 7+3 with GO, gemtuzumab osigomycin, the anti-CD33. And the dosing schedule that we use, as you would look around, you see different people doing different things. So I'm just thought maybe I'll put the dosing that we use would be the cytarabine, the ARC, we give 100 rather than 200 milligrams per meter square for 7 days. And this is overlapped with 3 days at the beginning of daunorubicin, and we use 60. And I'm sure you all are familiar with that. But now the new thing is that anti-CD33 might be a good drug to add because its benefit has been diluted in high risk and intermediate risk. So you might as well use it in those in these population of favorable risk disease in combination with 7+3, not alone. I typically keep it for relapse disease with no really data to back my practice. Intermediate risk is where you don't know which way is it going to go after induction. So we say, okay, if it's wild type, that's wild type. If it's wild type FLT3, meaning there is no FLT3 mutation, then use whatever you would use for favorable. 7+3 is fine. If it's mutated wild type, then you use a FLT3 inhibitor, midostaurin. And now FLT3 inhibitor, there is a plethora of FLT3 inhibitors that are coming to the market, even better than midostaurin, but this is the guy that got the approval and was and currently is in practice. However, very soon we'll have more approvals in FLT3 inhibitors. Poor risk, you got to break it down to, is it poor risk because it's therapy-related AML or AML with myelodysplasia? Because these guys, we know they don't do good. Their response to therapy is not great. And if that is the case, we might as well use something that might make a difference. And I will show you the liposomal cytarabine and daunorubicin data. It's really impressive difference, especially in those made it to transplant with us after being induced and consolidated with Vyxeos or liposomal cytarabine daunorubicin. Some people unfortunately don't have any targets. So what do? We just give them 7+3, and if they get to remission, we transplant them, because that's the goal, is to get them to transplant. In our practice, we transplant anyone who has intermediate risk or poor risk, as long as they have the appropriate donor. Generally speaking, we will find a donor. It's a matter of just getting them into remission before, because, as you know, we can get a fully matched sibling, which is great if we have, but if we don't, we have the NMDP that we do the search with their HLA typing and hope that we get a match, an unrelated match. Everybody signs up. And of course, I'll use this little second to encourage everyone to participate into the registry, to be part of this NMDP HLA typing and match, because minorities, including us from the Middle East and Africa, do not find a fully matched unrelated donor very easily, because the registry is full of Caucasians mainly, and their chances of finding it a match is much higher than the other minorities, except for Japan, which basically they have a very, very common genetic pool. The rest of Asia is also very poor to find it. And the problem is the participation in general, the participation into the NMDP. So all what you do is you just go online to the NMDP and get a swap. You'll get something in the mail. You swap the inside of your cheek and send it back in the mail, and you're on the registry. The younger people are generally the ones that we want. Younger than 40 is usually what we're shooting for. Most of the people that I pick is usually in their early 20s. But let's say we did not find a full match in those poor risk patients, and we have achieved full remission. We still can get what we call a haploidentical allogeneic stem cell transplantation, which basically half a match, and that's usually a relative, either a mother, a father, or a brother, or sister, or siblings. All those people, there's a potential of them. Most of them will have half a match. You just need one of them to be healthy, that you can collect their stem cells and use it to your transplant. And even if that fails, we have another bank of HLA typing. It's called the cord blood cell transplant. I'm sorry I went on a rampage on transplant, because that's what I mainly do. But the cord transplant is basically using umbilical cord in a cord bank that you do the HLA typing and find a match. Usually we try to have 100% match, and typically we need 2 cords to make for one adult allogeneic stem cell transplant load. But to get back to the discussion, elderly people more than 75 or with comorbidities that intensive chemotherapy is bad, they now have a chance to treat AML even if they come to you, to your practice. It's just recently approved just a month ago. Venetoclax and hypomethylating agent like azacitidine or decitabine. It's also approved venetoclax with hypomethylating agent, or venetoclax with low-dose Ara-C. Low-dose Ara-C, in my mind, is something that we should not use. The benefit of it is really low, and I think the heavy lifting is done by venetoclax by itself in that group. But venetoclax with hypomethylating agents is such a good combination in those elderly who are diagnosed with acute myeloid leukemia, or those who have comorbidities that you're thinking chemotherapy will be detrimental to their life and they won't survive it. So what do? You give them venetoclax, and venetoclax is such a smart drug. It's a BCL2 inhibitor. It's a small molecule that goes and inhibit BCL2. BCL2 is an anti-apoptotic marker that if you would incur an apoptotic process by the use of venetoclax, and you use that. So it's really not focusing on any genetic mutation in AML. It's agnostic to any type of mutation. However, it's very well tolerated, and it's a pill, so that's great. And then hypomethylators I like more than low-dose Ara-C because they are very well tolerated as well. either azacitidine or decitabine, and they do very well in those in that group. This is an approach that I made for myself, okay? And this is an approach that you might have. Some of it is data backed up, and some of it is not. And some of it is actually not backed, but in clinical trials. So what are these? Therapy-related AML, or AML with myelodysplastic feature, if they are fit, if they are good, healthy, and in shape, CPX-351 or the liposomal daunorubicin with cytarabine, in my mind, should be the standard of care, especially in those who they did the clinical trial on, which is more than 60. In my mind, I use it in everybody who has a therapy-related AML or AML myelodysplasia. Why? Because it just works better than 7+3. Also, we have to remember, it's more expensive, so that's a drawback to it. If they are unfit, Now, this is not a clinical trial anymore. This is approved in the unfit AML in general, not even therapy-related. You can use hypomethylators with venetoclax. In therapy-related AML and AML-MDS, it's just another AML with bad prognosis. All right, so that's in that group. In the next group, the next category is the CD33 positive, so which is most of AML, if not all. But with the drawback, it does not have any adverse risk karyotype. So good risk CD33 positive AML, we can use 7+3 plus gemtuzumab ozogamicin. We use gemtuzumab ozogamicin plus 7+3 in those situations if you want. However, in unfit, then it's a tough situation. As always, you can use hypomethylators. As I mentioned, my restrictions on the low-dose RC, or you can just use gemtuzumab ozogamicin on its own. Now, let's say it's not therapy-related and it's not a good risk AML, but it has FLT3 mutation. Then FLT3 mutation, the presence of FLT3 mutation has advanced our approach now that we can actually incorporate those inhibitors to FLT3. It's been known that FLT3 has a bad prognostic, is a bad prognostic marker in AML. However, now we have a drug that can work on it. There's one approved, 4 in clinical trials that will be approved soon. FLT3 mutation, you would still use 7+3. So chemotherapy is well alive. It's not dead. In 2018, almost 19, your chemotherapy in those patients is the backbone of treatment, but you're adding more precision into your therapy, meaning customizing that to your patient, to every specific patient, based on their genetic profile or genomic markers. So you would incorporate here midostaurin. If they are unfit for chemotherapy, you might use hypomethylating agent like azacitidine or decitabine. I prefer to use azacitidine in first line. It's a subcutaneous injection and very well tolerated, and reserve decitabine to later because I can use different hypomethylating agent with a potential of response plus hypomethylating agent. There's no approval in this. It's not approved as a combination, but we use it all the time and we believe it makes a difference. It's just a matter of time to get approved. The next marker out of the 4 categories that I have in my mind when I'm treating this is IDH. IDH mutation has arrived, and there's actually 2, IDH1 and IDH2. IDH mutation has appeared to be closely correlated to the survival of those acute myeloblasts. And the way that you can treat them is actually using an anti-metabolite. It's something that is going to inhibit the metabolism. It's going to the Krebs cycle, if you remember that, and stop the cells from proliferating by inhibiting an enzyme in the Krebs cycle rather than inhibiting or killing the whole cell together. So inducing apoptosis via affecting a mitochondrial involved as well as cytoplasmic involved enzymes. And the IDH1 mutation has anacetinib approved for it, which is not an approved drug for first line. It's approved in relapse refractory currently. Bear in mind, IDH inhibitors, in my mind, is a clinical trial to be used in the front line. It is approved as a single agent in the second line for relapse refractory. IDH mutation can be present on diagnosis. That's the point. It can be acquired later on as well. So it can show up later on in the treatment, in the disease. And that's how you should keep an eye for these genetic markers that those smart people in pathology can find. If it's IDH1, you use anacetinib. And if it's IDH2, if it's IDH2, you use anacetinib. IDH1, you use ivosidenib. And both of them are approved drugs in the second line, meaning in relapsed AML. It's a clinical trial to use it in first line. Also a clinical trial to use it in unfit patient in combination with hypomethylating agents. Is this the way to go? Well, clinical trials is going to tell us, but I would bet it will be the way to go in these people with this mutation. I would rather use it earlier than later and get them the best shot in remission. Now, let's say they are, as what I call, quadruple negative. They don't belong to any of the three groups. If they don't belong to any of the three groups, they are not therapy-related AML or AML with myelodysplasia. They do not have. They are not a non-adverse risk karyotype CD33 positive AML, or they don't have the FLT3 or IDH mutation. Then you just go back to what we did 40 years ago. 7+3. We got nothing better. 7+3 stands is still the way to go. And then if they are not fit, that's where we have the new approval now. It's not a clinical trial anymore, where you have HMA with venetoclax or HMA with or low-dose ARC with venetoclax. So this is the new standard in elderly and unfit or patients with multiple comorbidities. So this is just the way that I look at it. That's how if I don't have, the first question is always, is there a clinical trial? If there's no clinical trial, then I go, where do they fit here? And that's how I treat them. So now, since we're talking about drugs that are newly approved, I thought maybe I should talk about those drugs so you know about them. And I'm sure some of you who are involved in this field heavily are already aware of them. So midostaurin is the first approved FLT3 inhibitor. It's the first approved FLT3 inhibitor. We used to use sorafenib, which is a drug that is more used in thyroid cancer and liver cancer because it has some FLT3 inhibition back in the days before we have the midostaurin approval. Okay, so now midostaurin has taken place of sorafenib in that regard. It is not a pure FLT3 inhibitor either. It's a promiscuous inhibitor. It has multi-targeted kinase inhibitions. So it goes from VEGF to PDGFR, stem cell factor, as well as FLT3. So even though we are calling it a FLT3 inhibitor, the effect might not be only based on FLT3 activity. All right? The labeled indication is only in FLT3 positive AML. The approval was last year in April. It's oral. You take it. You have to take it with food, and you take it in first line with chemotherapy. So you take your daunorubicin and cytarabine 7+3 induction, and after you finish the 7 days of chemotherapy, day 8 you start your oral, and that's when we start chasing pathologists down the hall, because that's the problem here. We have to, AML is generally an emergency. We have to start the treatment as soon as we know that it's AML. But FLT3 status take a while to come back. So now we are getting more and more very efficient. Our pathologists and labs are getting very efficient in getting us these results within 2 to 3 days, because the other problem is it's not just we chase the pathologist and once they give us an answer, we have the drug over on the shelf, we can give it to them. No, we have to order it and it comes from a specialty pharmacy. So that gets shipped and take 2 to 3 days to come. So we have only 7 days from the diagnosis and start of treatment until we give that drug. And that's usually, we are having it raised with time. It's a hepatically metabolized, but no dose adjustments required for baseline hepatic impairment. In the trial that I'm going to talk about, it's called Ratify trial, they just excluded anybody with 2.5 above the upper limit of normal total bili. A little bit about FLT3 gene. FLT3 is located on chromosome 13. It encodes for FLT3 receptor tyrosine kinase, which is expressed on the majority of leukemic blasts. So once you have that mutated, those proteins that spontaneously dimerize, causing factor-independent growth and fatal myeloproliferative neoplasm in murine models. So we kind of know and understand very well how the FLT3 plays a role in acute myeloid leukemia. However, it took us so long to find a drug. And guess what? It's not uncommon to have it. FLT3 is not just FLT3. There's multiple domains that you need to actually check which FLT3 is it. It can be ITD, internal tandem domain duplication, and that one is present in 25 to 30% of de novo AML, and it's present in 15% of MDS-derived AML. And we know that it has a poor prognostic value, and it increases the risk of relapse and reduces survival. The TKD, the FLT3 TKD, tyrosine kinase domain mutation, is less common and unclear if it confers any poor prognosis. And that's when we look at the clinical trials, and the clinical trials tell us what to do. And here is Ratify. Ratify was a phase 3 randomized, double-blind, placebo-controlled, used people younger than 60, older than 18, younger than 60, who were diagnosed with an AML with FLT3 mutation. They were either given placebo plus 7+3 or midostaurin plus 7+3. And look at that. Overall, the median overall survival was 25.6 months in the placebo arm compared to 74.7 months in the midostaurin arm. That's 50% higher. That is nothing that you can argue the efficacy of this drug in this population. Again, mentioning the overall survival, and those who ended up with a transplant as well had good outcomes. Toxicities, most common is myelosuppression, cutaneous, and GI. This is the most common things. And remember, we're looking at them in combination with chemotherapy. So it's midostaurin plus chemotherapy, had more anemias than the placebo with chemo, and more rashes, as well as more GI toxicity. The rest of them were not really clinically significant or statistically significant difference between them. This is a busy slide, I apologize for that, but this is just basically the key points for what midostaurin. Midostaurin, we know in FLT3 positive AML improves overall survival and event-free survival. Regardless if it's ITD or TKD, FLT3 works. Even regardless of the ratio, it still works. If it's high ratio or low ratio, you should use FLT3 inhibitor if you find it. It reduces the risk of death by 23% compared to placebo. And the benefit in therapy is usually derived early in therapy, and you can notice it after only 42 days. The question, and that's not been fully approved or resulted in clinical trials yet, and it's ongoing, is maintenance therapy, which is after transplant or after consolidation. Should we keep them on the pill once they have achieved their complete remission after consolidation, or once they have been transplanted? Because mostly we transplant those people with 3 mutation. The age, FDA approval, even though the clinical trial was 18 to 60 or younger than 60, and older than 18, the FDA approval had no label age restriction. So you can use it in anyone. You can use it in 80 years old, in 90 years old if you have one who can take a pill. However, it's an oral combination, and you know that oral combination in the setting of induction chemotherapy is not always the most tolerated therapies, because they are having chemo-induced nausea and vomiting and such that you're not sure if they're actually keeping the pill down, or is it absorbed appropriately with all the enteritis or colitis induced by the chemotherapy. Remember that it's a CYP3A inhibitor, and and those inhibitors can increase the midostaurin exposure. However, when they did that, there was no notable increase in midostaurin-related adverse events. It interacts with NPM1 mutation. So EFS as well as OS benefit most pronounced in those who were wild type NPM1. So wild type NPM1 did better when you give them to that compared to those who had NPM1 mutated in the presence of FLT3 mutation. You have to take it with food. That's why we prophylactically give them antiemetics, so they keep it down. There was slightly increase in QTc prolongation, and we should maybe watch it. Questions for the future: how to best combine it? Should we actually just do it continuously from day 1 of diagnosis, or once we have the drug, we start it as soon as we can? There's no point of waiting those 7 days. Or should we wait until we achieve remission and then use it? Who knows? Clinical trial will tell us. Role of maintenance therapy in high-risk patients. Those in high risk, should we put them on it as a maintenance? Should we put them on maintenance for 6 months, 1 year, 2 years, forever? I don't know. Clinical trial will tell us. And then concurrent versus sequential therapy is another question. Now, CPX-351, and that's the liposomal daunorubicin with cytarabine. So bear in mind, this is a liposome. This is a liposome. So you see the biphospholipid layer surrounding a what do you call that? A synergistically combined ratio of 1 to 5 of daunorubicin with cytarabine or cytarabine with daunorubicin, and that's just a vehicle. The liposome is just a vehicle carrying in the drug, the chemotherapy, the same chemotherapy, just in a new delivery. And apparently, when you give it inside a liposome, it lives longer in the bone marrow, and it does not increase the toxicity outside the bone marrow, and it maybe clears the cancer better. And it's proven. In high-risk patients, specifically those with therapy-related AML, or AML with antecedent MDS, or AML with myelodysplastic features, those people had a phase 3 randomized trial that got 7+3 compared to CPX-351 or liposomal daunorubicin. And here is the overall survival difference: 5.9 months versus 9.6 months in the CPX-351. The interesting part is that's not all. That's not all the benefit. Those who achieved complete remission and went on for transplant, let me show you this. Those who went to transplant, look at this. Look at this difference. That's a massive difference between who achieved complete remission and received CPX-350 compared to those who achieved remission and went to 7+3 after transplant. That's a massive difference in their Kaplan-Meier. All right, quickly, the most notable toxicities in CPX-351 is prolonged cytopenias that can be beyond even the typical 3 to 4 weeks of cytopenia in 7+3. So they might be in the hospital for 5 or 8 weeks while we're giving them this. And we typically do the induction inpatient. I know some other centers don't, but we typically do it inpatient until they clear it. And they can consolidate outpatient with Vyxeos, with the CPX 351. We know now that CPX 351 is superior to 7+3. Both 30 and 60-day mortality are lower in CPX 351. Overall survival after transplantation is better. We know that is better in CPX 351. It's a very effective bridge to transplant, and it cannot be substituted across the board for all 7+3 appropriate patients. It only would be usable in those. Remember, it has a substantial longer half-life because of the liposomal formulation, and that leads to prolonged cytopenias. Gemtuzumab oxazomycin, or Mylotarg, or the anti-CD33. This is the drug right here. This is the drug. It binds to the CD33 on the surface. It carries this poison. It's called calicheamycin. Calicheamycin and the drug get carried inside. Then once they're internalized, they start inducing DNA damage, breaking it down, releasing all these cytokines that leads to cell-induced apoptosis and death. And also suppress more of those survival signaling markers. And guess what? The drug does the job and then goes on to do its job somewhere else. And this was approved, as I mentioned earlier, in 2000. However, it lost its approval. It lost its approval at that time because of the toxicities with the veno-occlusive disease or sinusoidal obstructive syndrome, the hepatic toxicity that was thought to be secondary to the drug. And the drug was withdrawn from the market in 2010, however, was reapproved just last year. Enasidenib is the IDH2 inhibitor. It's present in about 2% of the patients. It comes in usually with people with normal karyotype and increase in frequency with age. This is just the CRIPS subcomponents with the mutation. There is an increase in the hydroxy. With the blockage of this mutation, there's an increase of the R2-hydroxyglutarate, histone, and DNA hypermethylation, leading to blocked myeloid differentiation, and that's how you get stunted into the blast phase. And then the enasidenib induced inhibition of mutated decreased these beta-hydroxyglutarate by 90%, reducing that abnormal histone hypermethylation as well as restored myeloid differentiation. Remember, it's because of that, it's a differentiating agent, so worry about differentiation syndrome the same like you worry about it in ATRA, in APL. This is a clinical trial, phase 1/2, that got its approved 100 milligrams. It's an oral drug, selected for dose expansion, and that's the beauty of this drug. It's based on pharmacokinetics and pharmacodynamics and efficacy rather than the maximum tolerated dose, which is been used by our ancestors as the goal. Now it's pharmacokinetics, pharmacodynamics, and efficacy, which is great. Makes me happy to look at that and see it. Very important, I know time is running. So nausea, vomiting, diarrhea, and elevated bilirubin is one of the markers that you need, one of the adverse events that you should keep an eye out for. Differentiation syndrome is similar to that one of APL. I won't repeat talking about how you treat it. The white count can go up, use Hydrea to bring it down, dose adjust for Billy and any other grade more than 2 events. Relapse AML very quickly, aggressive chemotherapy, use all these combinations of chemotherapy for it, either cladribine, fludarabine, or mitoxantrone etoposide-based regimen, or clofarabine if you feel like treating it. That way, if you can't go an aggressive approach, you can use hypomethylating agents. If they have HMA, if they have a FLT3 positive, you can use hypomethylating agents. And I would not use this. I would try to get them on a clinical trial with gilteritinib, crenolinib, or crizotinib. IDH2 is enasidenib, and please also don't forget, and that's my bad, ivosidenib, which is an IDH1 approved drug currently. CD33 is gemcitabine. Very important to look, this is just one slide, in the measurable, or what is commonly known as minimal residual disease assessment. We now know that this assessment is the way to go to know if your treatment has worked or not. And this is a diagram that is telling you those who have achieved NPM1. So if somebody with acute myeloid leukemia who has NPM1 and it was negative on induction, after induction, they have a 73% chance of being alive after 5 years compared to those who have that being positive. And this is in people who have achieved a complete morphologic response. So MRD assessment is a big deal. MRD assessment can be through next gene sequencing or via flow cytometry. This has not been standardized. And this is in general. MRD negative patients after therapy do much better than MRD positive. And now we're trying to understand how can we utilize this. What test is next gene sequencing that should be used? Well, that's very expensive and it takes time. Or should we depend on a multicolored flow cytometry? Once we have any AML patient, quickly we consider them for transplant. Are they a transplant candidate? We talk about the procedure and the risk and see if the patient is actually willing to take that risk. We talk about all the treatment history and the possible and the toxicities they've gone and how much transfusions have they need. And we talk about their disease status, other organ function, performance status, how much are they actually able to do. We don't transplant anybody who is just sitting in chair and can't do anything. And psychosocial assessment, we need a caregiver. That's one of the biggest things that we need is a caregiver. We know it correlates with survival. This is a history of transplant. In 1956 was the initial report on use of bone marrow transplant as a cancer treatment. They used it in, they performed a twin-to-twin transplant, like identical twins. They transplanted one to the other and it worked in the 50s. And then they used bone marrow transplant. This cowboy in New York used it in for a radiation accident. I believe family members from Ukraine or somewhere in Eastern Europe. He transplanted them because they lost all their bone marrow with the radiation exposure. And then all these other steps in the transplant, HLA, ideas of matching allogeneic bone marrow transplant for immune deficiency, then leukemias. And you can see that, interestingly, autologous stem cell transplant has actually came after the use of the bone marrow transplant itself as I think so autologous, which using the own patient's cells to transplant them after we beat them with chemotherapy, was discovered or as a utility in transplant after allogeneic has been already studied. And this is just the difference in numbers. Autologous is being done a lot. It's a less comprehensive of a therapy that we do mostly for our myelomas and relapsed lymphomas compared to the allogeneic patients. The allogeneic stem cell transplant that takes a couple of years before they can actually get back to regular life if they can. Conditioning regimen is a big thing, and honestly, this doesn't do it a favor because we have our regimens here is FluBu2, and our regimens here is FluBu4. Is that what we use? Unless it's an ALL, we use CyTVI, and these are simple regimens that we stick to. But this is different regimens across the board, from the least aggressive to the most myelosuppressive, as well as the most immune suppressive. So the curve has multiple dimensions to it. Anything that crosses this line, actually this line right here, you need stem cells. You won't recover on your own, or will take forever, and the risk of death is high. Non-myeloablative hematopoietic stem cell transplant is a thing that we have, that the Fred Hutch has pioneered in Seattle, and giving less chemo, letting the two cells live together, and then incorporate the immune suppression therapy to let the graft survive longer by less, going down on the immune suppression as we go. And then the future, and I'm sorry I talked too much, but the future is chimeric antigen receptor T cells. That's the real deal, and that's what I'm really excited about to talk about. But right now, we're still working on our own construct, as well as other big centers, the much bigger centers than ours, are doing already their clinical trials on CAR T cell therapy. What is CAR T cell therapy? CAR T cell therapy is chimeric antigen receptor T cells, meaning we take the patient's own T cells. So we freeze the T cells out of the patient, we take it to a lab, and then the lab, we genetically, we get this vector, a viral, that carries a tool to develop those antigen receptors that can be incorporated into the DNA. So we transfect it into the T cells and make this CAR T cell product. Once you make this CAR T cell product, you insert this gene into the T cell. Now it's a chimeric antigen receptor T cell. You expand it, you give it to the patient. Usually here, we give some conditioning, just a lymphodepleting conditioning, cyclophosphamide and fludarabine. And then those cells go chasing after the cancer cells because they have these detection tools. So they go checking after them because we know our T cells can kill the cancer cells. It's just the cancer is so smart in hiding its markers. So we give those markers to the cell and give it back. It's a very expensive therapy, extremely expensive therapy. The approved drugs are about $400,000 to $500,000 for just the drug. It's not include the hospital costs and the care aside from we call it a drug, but it's T cells of the patient. But Novartis and others, that's how much they are charging to give it, and became really limited. In CAR T cell, in AML, you have the CD123. City of Hope is working very good at this, have very early reports, nothing really coming to big deal. University of Louisville here, and this is my project that I'm hoping that we can bring into light sometime next year, is a compound CAR. So instead of having one marker on top of the T cell, we actually have two different ones. So the cell doesn't have that one. It can carry, it's likely going to carry the other one, and we can ablate it that way and get rid of it. So it's called a compound or a dual targeted chimeric antigen receptor T cell product. And hopefully we'll be able to start that within the coming year once the FDA approve our lab. Again, I go back to our proposed approach. This is how I do it, simply speaking. And in summary, genetic risk stratification has been a very, very valuable therapy that gives us treatment guidance. Combination of targeted therapy and chemotherapy is now the standard, and we should always look for those targets to use instead of just throw 7+3 on everybody. MRD assessment has been proven to make difference. The only thing is we still don't have a standardization of what tests and what should be tested. Next-gen sequencing is definitely the way to go, but what next-gen sequencing entail is also not very clear. Allogeneic stem cell transplant is the way, is the only curative approach in relapse refractory, in relapse disease, and those high-risk de novo AML. And CAR T cells will play a major role in the future of AML therapy. I apologize for crossing my mark for 3 minutes. Thank you very much, and I would welcome any questions.
اتفضلوا يا جماعة لو حد عنده أي سؤال. فيوم Oncology Center.
Thank you.
Thank you very much.
Thank you very much for your lecture,
Pleasure.
Dr. Hegazi.
It was my pleasure. Thanks.
Thank you, Dr. Hegazi. I personally learned a lot from you today. Thanks so much. It's nice to see the clinical aspect of things.
It's my pleasure. Thank you for your time.
Thank you. Thank you. Thank you for your time.
It's my pleasure.
Mohamed, and I wanted to attend your lecture from Fayoum Oncology Center so that we could also discuss like our plans for next year for 2019 with Dr. Mohamed. But unfortunately, he was ill, so I couldn't go. But inshallah, we'll try to arrange a meeting, another Zoom meeting, we can talk about the different we do with them and for 2016, 2019, inshallah. And I thank everybody for joining us today, and أشكركم ألف شكر وإن شاء الله Until next time, inshallah.
Thank you.
Yeah, inshallah. Oh, wait, yeah. Dr. Mohamed, I think the oncology wants to say something. That's fine. Okay, Allah, take care of you, Mohamed. Inshallah, we'll be in touch, okay?
Okay.
Okay. All right. No questions. Thank you.
Have happy holidays, inshallah.
Thanks.
You're
Right.
welcome.
Awesome.